Welcome, everybody. I think we'll just get started. My name is Alan Clark. I'm the Knowledge Coordinator for Mental Health and Substance Use. And today we will be looking at perinatal depression and anxiety, mostly depression. And we have Vickie Kampe and her student Brittany Willment with us today.
Thank you, Alan. Welcome to our presentation titled Addressing Perinatal Mental Wellness. My name is Vickie Kampe. I'm an ASTAT clinician at Penticton Mental Health and Substance Use Programs.
And I'm Brittany Willment, and I'm a student with Vickie, and I go to Yorkville University.
Today we want to share with you the key points of perinatal mental health. In BC, as many as 1 in 5 women will experience perinatal mental health disorder, and only a small number will seek help.
So today we want to share information on evidence-based practices that include psychoeducation and a focus on attachment with baby. And we're also going to look at how to support a parent in getting support and increasing self-care, as well as looking at the streams of public health nurses, mental health clinicians, perinatal social workers that work with postpartum parents, and how these streams work together and collaborate.
In 2014, the BC Reproductive Mental Health Program and Perinatal Services BC, along with the Ministry of Health, developed the best practice guidelines for mental health disorders in the perinatal period. So the information that we're presenting today is from this document.
So today we're going to talk about the 4 pillars of action that have been identified by the BC Reproductive Mental Health Program. So they are education and prevention, screening and diagnosis, treatment and self-management, and coping and support network. So although mental health disorders during this period are very serious, it's really important to have strategies and team approaches to have early care and effective treatment.
So awareness of different mental health disorders and having knowledge of the symptoms in order to recognize and reduce stigma is useful for treatment providers and general population. The perinatal period is defined as from conception to 1 year postpartum. And any mental health disorder that is diagnosed during the perinatal period requires a specifier on the DSM-5. So, for example, major depressive disorder specified with peripartum onset. A key point to providing psychoeducation to women with a mental health disorder in the perinatal period is that it helps reduce their distress. So it helps women understand that they're not alone in their experience. It normalizes the challenges of motherhood and becoming a new parent. And I think it's also really important to recognize that many of the depressive symptoms and anxious symptoms, anxiety symptoms, are typically what every woman who has delivered a baby experiences in the postpartum period. So, for example, changes in weight, changes in appetite, changes in sleeping patterns, just difficulty concentrating, and hypervigilance.
So mental health disorders are very serious. They include the negative effects on the mothers, and they often can see that their baby's behavior might be really difficult. They might not be responding to the baby's cues appropriately. Oftentimes they may breastfeed for shorter periods of time, and also the relationship between mother and baby is affected. So these are the reasons why we need to support in this area, because if it's untreated, it can get worse. It's going to impact attachment, and it's also going to affect the child's development, including social, psychological, and educational development. Babies may cry louder and longer and experience developmental delays. And in extreme cases, it can result in psychosis of the mother, suicidality, and infanticide. It's also important to address the relationships and families with mental health disorders and the increased risk of separation and divorce. And finally, the partner is also at risk of depression when a mother is experiencing mental health. So some of the barriers that we need to talk about is stigma is a huge one for going for help. So the stigma is related to the things that we see in the media, beliefs about the self, also a lot of guilt and shame in asking for help. And that's when we need to look at some cultural considerations that might need to be made. It's also common for lack of knowledge about the normal adjustment period of becoming a parent. What is the baby blues versus what is something that actually needs help? And mothers often will minimize their symptoms and think, oh, maybe this will just go away if I ride it out long enough, as well as lack of awareness about the implications that if they do leave it too long, what untreated mental illness looks like. So other concerns are concerns about the baby being removed from parental care, and then perhaps mothers may not have childcare or a way to get to appointments for mental health. And finally, most women, they need the support of their healthcare professionals. They need support from families and friends to actually make the jump to seeking help with the mental health disorder.
Okay, so the next slide lists the different risk factors. Best practice is to provide support and services for women who have risk factors. They may not meet the criteria for a clinical diagnosis, but if we acknowledge the risk factors and monitor them through the 3rd trimester and up to 6 months postpartum, we get the best prevention and treatment results. So the highest period of risk is during the 3rd trimester of pregnancy and the first 3 months following a birth. And so risk factors may be difficult pregnancy, a difficult birth, poverty, poor self-esteem, addictions or history of addictions, if they have a history of mental health disorders in their family or their own personal, and stressful life events in the 2 years preceding pregnancy.
So there's many signs and symptoms, as you can see here. The DSM-5 is the best guide for making a clinical diagnosis, so that's where you want to refer to.
In terms of education and prevention, a very important first part of the treatment is providing psychoeducation to the mothers and family members and helping them identify their own personal and family risk factors.
So here we have the clinical picture. So a mother that is experiencing postnatal mental illness, she might look unkept or meticulously groomed. Oftentimes the face is pale. She might be miserable and kind of indifferent and ambivalent. Oftentimes if you ask the mom, like, how's it going, she might say, oh, I don't know, like just not really either way. She's going to have a flat affect. She won't be kind of smiling and interacting with baby. And there might be a time lapse from when the baby's fussing to when the mother's actually interacting. She might not have any makeup on, wearing hair in ponytails, kind of wearing the same clothing all the time, and all around kind of poor hygiene that's noticeable. She might also be really overwhelmed with the demands of caring for baby, and all in all not really enjoying the role of motherhood.
The behaviors that you may see presented would be crying very easily, really coping well with the sleep deprivation and complaining a lot about having interrupted sleep due to meeting the baby's needs. Present as the baby is sleeping, but the mom isn't sleeping even though the baby is. Reacting emotionally to small stressors. Behaviors could also look as checking and having, like, being concerned for the baby's well-being. Sometimes if there's difficulties with breastfeeding, anxiety can increase if the baby is slow to gain weight. That can be very stressful for the mother. And another behavior might just be like low mood, irritability, and that comes out with, you would recognize kind of abruptness in communicating with others. Often depression and anxiety go hand in hand. We're biologically wired for our senses to be heightened after the birth of a baby. So our senses put into a hypervigilant mode naturally, and that would be to hearing, which could lead to very light sleep, smell, sight, and so really during this period it is normal to feel anxious, but it's when those levels of anxiety and depression interfere with functioning when services and care are required. So anxiety, the symptoms of anxiety are extreme worrying, racing thoughts, over-concern about the baby, panic attacks, intrusive thoughts, changes in appetite, and changes in sleeping patterns.
So for mothers, this isn't just a one-sided thing. It's really a multidimensional reality. So it is not just emotional dysregulation of not being able to cope. It's happening on a physical level with hormone changes. The mom might be recovering from surgery, learning how to breastfeed, all the different body changes that have been happening. Might be on a personal level, such as a tendency towards perfectionism. They might have fluctuating moods. They might be really self-critical or have high or low energy levels. It could be on an environmental level, so moms that are isolated, have partner conflict, and are really living in stressful situations. And on a society level, it could be poverty, addictions, the myths of motherhood, cultural expectations, and their own expectations about motherhood and pregnancy. And finally, important to talk about the historical reality of personal issues often come at the time of postpartum. There might be unresolved grief, childhood abuse, sexual abuse, and family dynamics. And also, this is a time of loss for mothers sometimes. It might mean loss of identity, loss of freedom, changes in life plans, and loss in relationships.
Okay, so early identification and early treatment are the most realistic strategies for combating perinatal mental health disorders. Screening and diagnosis. The Edinburgh Postnatal Depression Scale is a very useful screen for identifying postpartum depression. It can be used for parents, not just mothers, and it's available in many different languages. So it's important to note that this screening is for perinatal depression. It does not identify postpartum or perinatal anxiety, although both depression and anxiety are often present at the same time. In interior health, there have been some program developments in where public health nurses will begin routine screening using the Edinburgh, starting in the late fall and early summer. They're preparing to implement this. The perinatal social worker in the South Okanagan will also have a role in following up with mothers at the maternity clinic and at their 6-week appointment. Other maternity clinics often use this scale at the beginning of the 3rd trimester of pregnancy. So if screening indicates possible depression, it's a good idea to make referrals to the mental health services.
So this is the EDPS questions, and they're just the basic questions that really pull out the different signs and symptoms of postnatal depression. And
on this slide, we're looking at how to interpret the scores. So a score less than 8 would suggest that that depression would not be likely. Any score higher than 12 would indicate that there's a high possibility of depression, and so at that time, support and education, that's a good time to offer support and education. And if a score is higher than 14, it's probable depression, and that would be when you would make the referral to mental health services or family physician.
So actually that begs another question for me. If a non-PHN has done an Edinburgh, are we repeating it?
You might be. It's okay if it's done more than once, right?
Yeah.
It has a scale, it has reliability, and
And the scale is only 10 questions long, and so really to implement the scale, it doesn't take a lot of time, and symptoms can change over time, so that might be like a beneficial thing to do.
So if you have done a suicide risk assessment and the risk is deemed high, so a mom that has thoughts, plans, and means without any protective factors, it's really important to consider the risk to the infant at all times. So the baby's safety is really paramount. So we're going to ask questions about who will be responsible for the care of the baby and supervision of the mother's care. And if appropriate, make contact with the partner and other family members that might be involved. A social worker at the Ministry of Children and Families should also be contacted to ensure that they're able to assess the suitability and alternative carers or supervisors and assess the home circumstances. And also, it's really important to have good communication between all agencies, including the treating physicians, and this is vital for the safety of the baby as well as the mother.
Okay, so another pillar to these services is treatment and evidence-based practices and knowledge. So we've talked a lot about the important role of providing psychoeducation to service providers and expecting parents and the general population, and also to the mothers who are living it and struggling. So these are some other important strategies to consider in treatment. When we review signs and symptoms, that helps mothers increase their own self-awareness and normalizes their experiences. And also, there's like a reassurance that usually lessens the distress of not doing well, that knowing that kind of struggling emotionally is a natural part of kind of entering motherhood. So self-care, so nutrition can often be forgotten about as parents are so focused on their baby, and proper nutrition can help manage the low energy and gives emotional resilience. So social support also plays an important role in helping new moms adjust to their life changes that go along with being a mother. So healthy relationships are a really big part of a protective factor against depression. Encourages women to consider who their people are and to know where they need to go to ask for help. And guilt about asking for help and thoughts about feeling undeserving or as a burden is often present in these moms. So it's important to point out things that are like, other people are really flattered is something that I like to tell people when you ask them for help. So that's something to tell a mother, to let them know, and also to ask for help with the practical things. So when we look at these kind of components to self-care, nutrition often has an impact on the symptoms of like low energy and low motivation. And then sleep and rest is kind of a difficult one to navigate too, because sleep is often interrupted by meeting the needs of a baby. So that often, if that's what needs to be addressed, you know, sometimes we're looking at combining support plus addressing sleep and rest. So asking for people like, you know, supportive people in the support network to come and assist the mother so that she can get more sleep.
So in the mind-body modalities, mindfulness and self-awareness is really important for developing awareness around a mother's own hunger cues as well as their baby's hunger cues. It's important that they can become aware of their own mood as well as their thinking patterns. That can really be the building blocks for setting up CBT strategies later. And also mom and baby yoga, pre- and postnatal yoga, and other types of yoga are important for the mind-body modalities.
Okay, so cognitive behavioral therapy, there's lots of research that shows that this is one of the best forms of therapy in addressing mood disorders. I like to start with the first step of teaching the difference between thoughts, emotions, and behaviors. I like to use thought records to challenge negative thinking patterns and help mothers develop accurate and more factual-based thinking. Because what we know is that there's a link between thinking and emotions, and so when mothers are able to learn the difference between thoughts and feelings and how their thoughts impact their feelings, that also helps kind of manage the mood. And today we're going to spend a little bit more time looking at unwanted, disturbing, and intrusive thoughts. But another part of CBT is looking at behaviors, and so that would be mostly focusing on self-care behaviors, which we just reviewed. So this is where we want to do the YouTube video.
Oh, okay. So we're going to go to a video here. Okay, so hopefully people can see that okay.
So let me start by saying you've done a good thing. You've done the right thing by taking this course.
Yeah, so that was just a quick video on an example of an intrusive thought. So the definition of an intrusive thought is something that's unwelcome and involuntary. It can be an image or an unpleasant idea that might become an obsession, and it is upsetting and distressing, and it's really difficult for the mom to manage or eliminate. Women begin to avoid situations like bathing their children, for an example, that might trigger the thought.
So there are two different kinds of intrusive thoughts. The ego-syntonic thought is very rare, and it's a situation where mothers need to be hospitalized immediately. It's when a mother's thoughts of ending her baby's life does not cause her distress, and it's kind of like a belief that the baby would be better off dead, and she has no insight around the implications of this kind of thinking. The second kind of intrusive thoughts, they're more common. It's the ego-dystonic thought. It's where mothers are aware that their thoughts are irrational and that they don't want to act on the thoughts. And also the idea of those thoughts creates an emotional distress for them. And they often kind of go into this pattern of like trying to find meaning of why they've had that thought. It must mean they're a bad parent or they're evil or something, you know, and they go into this kind of vortex of trying to make meaning, and then a later outcome is guilt.
So in order to treat that, psychoeducation is really important. It can help normalize the occurrence of the thoughts. It would be really shocking for people to find out that 90% of mothers report having these types of thoughts. So often the thoughts are recurrent, but they're temporary and they're harmless, or they become obsessions and they're repetitive and highly distressing. So like Vickie said, typically mothers with the ego-dystonic thoughts, they don't act on their thoughts of harming babies. And that's important for mothers to know.
Making the CBT connection and pointing out the difference between thoughts and behaviors is a helpful approach here. This is also where using the mindfulness skills and having awareness of your thinking patterns is a useful strategy. I like to take the approach of teaching the mothers the skill of not engaging with the intrusive thought, and I kind of use a metaphor of the thought being an intruder in your mind, and that you have, a thought that's knocking on the door, and you have a choice to open the door and entertain that thought and feed it and allow it to become more and more distressing, or notice that the thought's knocking on the door and being able to state, no, that's an intrusive thought or an unwanted, disturbing thought. I'm not going to entertain that thought. This might be a good time to field questions here. Are there any questions around that? Because I know it's a lot of...
Yeah.
Can you give some other examples of intrusive thoughts? What are the kinds of ones you most commonly see?
So sometimes it can be like envisioning harm to your baby, so your baby being in an accident, or sometimes mothers envision like themselves harming the baby, or they'll envision accidents. So those are the kinds of thoughts that are like distressing, right? So, and then when they start to engage in like, why did I just think that? that's kind of where it becomes problematic. And then and kind of feeds the repetitiveness, because there isn't really an answer to why did I think that. So there was a study that was done, I'm sorry, I don't have the details on that study, but it showed that 90% of mothers have these intrusive thoughts. So it's so common, but it makes me kind of wonder if the other 10% who did the study were too afraid or ashamed to answer truthfully. So, like the incidence is really high.
So group therapy. So in Penticton, when there's enough participants, we run an 8-week CBT group that's open, and that's in collaboration with public health and the perinatal social worker program. And we provide information and facilitate discussions on mindfulness, activation, on cognitive reframing, relaxation, attachment, self-care, and problem solving. Other forms of treatment that are evidence-based, but we don't particularly provide them through ASAP programs, would be interpersonal psychotherapy. Sometimes it's important to address relationship difficulties during the perinatal period, so couples and/or family therapy. And depending on the severity of the diagnosis, medications, and ECT therapy. So on this slide, I'm speaking a little bit about the programs that we have in the South Okanagan. So we're fortunate for the mental health and substance use programs to have a strong collaboration with the public health programs. We provide individual CBT at mental health and substance use. And when we run our 8-week specialized group, we often have a multidisciplinary approach with that, where we're fortunate to have public health nurses co-facilitate with us and perinatal social workers. Right now, some program development is happening with Interior Health Authority, where we're engaging other partners, and this is coming from the suggestions made in the best practice guidelines for mental health disorders, in that we're starting to screen at the primary care maternity clinic and with OBGYNs and physicians. One of the steps that's being taken and will hopefully be rolled out in the fall of 2016 is screening at the 2-month child health clinic by the public health nurses. It's also possible to establish peer support programs and for clinicians to participate in community education. So some of the resources for clinicians are listed here. So the Pacific Postpartum Organization, the BC Reproductive Mental Health Programs, and the best practice guidelines that we've been discussing. They're all available online, and they're excellent resources.
So if you're working with a parent who may be at risk or who does have a diagnosis of a mental health disorder, resources would be the family physician, HealthLink, public health, adult mental health, and some of the websites that we mentioned earlier.
Not to leave dad out, there's lots of good web-based resources for dads that you can see here that might be useful in sharing.
Yeah, a question did come in about this particular piece. Are there instances of male postpartum?
Yes. So I think that even with a father who is having a difficult time adjusting to the arrival of a baby in the family, that would also be considered, like an important piece, because that would impact the baby's attachment and kind of the family unit. Yeah. So it's important to engage fathers too.
Okay. Well, thank you very much. Maybe we can just open up for any further questions. Yeah, so does anybody have any comments or questions or thoughts or maybe something interesting that's happening in your area? Yeah, there's a note here from public health nurses in the East Kootenays. They've been using the Edinburgh tool for a few years and use it regularly at 6 weeks with a phone call and or the 2-week month CHC. So, and I think that's a big part of where public health is going, is to make this a standard procedure. Okay, well, we will just wind it up then. I really want to thank Vickie and Brittany for taking the time and doing this. It's always a little nerve-wracking when you have to stand up in front of a computer and talk to a screen. And so we really appreciate you doing this and, you know, and all the great work you've done over the years for this population. So take care and have a good day.